Thank you, Axel. Thanks also to you and David for the opportunity to participate in these interesting debates. Actually, before coming to Mayo, I spent about half my life in the New York, Connecticut area, so it's come to feel like a second home to me. It's a real pleasure to be back. These are my disclosures. There's no debate that this is the future of oncology, developing biologic agents that target a specific driver alteration or other molecular aberration. However, as we all know, the new biologics have doubled in price to an average of $10,000 per month, and they're adding to our unsustainable growth in health spending, plus their benefits are modest, and the lack of value is hurting some of our patients financially. Because we as providers have a unique perspective as patient advocates, we're increasingly taking on the responsibility of helping to determine what therapies have value and which ones do not, as our colleagues a few blocks from here in 2012 did with regard to aflibercept and metastatic colorectal cancer. We're moving from the mere evaluation of outcomes to the concept of value, which is defined simply as health outcomes achieved per dollar spent. If a treatment is expensive, we expect more from it. Right now in second-line gastric cancer, Ramaseraab, which is a VEGFR2 antibody, is the only biologic shown to improve overall survival in a population that's not completely Asian. This is shown in the Rainbow and Regard trials, which is where we'll focus this morning. My position that I've been assigned is that a biologic is not appropriate in second line because it lacks value. I'll start with the numerator of the equation, discussing outcomes for chemotherapy alone, then show that RAM adds minimal efficacy to chemotherapy, that RAM monotherapy has similar efficacy as chemotherapy, and that RAM has not been proven to improve quality of life. Then I'll discuss the denominator. For a costly drug, wouldn't we expect dramatic benefits? So let's start with chemotherapy alone. Chemo alone has been shown to improve overall survival over best supportive care alone in 3 phase 3 trials, totaling more than 400 patients. There's Cougar from the UK, which examined docetaxel. There's a Korean study which examined irinotecan or docetaxel. There's a small German trial. The results are quite consistent across all the trials. A median OS improvement of about 1.5 months and a hazard ratio of 0.67. It's reasonably tolerated as well. Hematologic toxicities were the primary toxicities, 15 to 30%. Treatment discontinuation due to toxicity, 13 to 31%. I added the toxicity data from the paclitaxel arm of Rainbow, which we'll cover next, because the sample size was large and it's consistent with showing how well chemotherapy is tolerated in this setting. Treatment discontinuation due to toxicity, only 12%. So how much does Ramaseraab add to chemotherapy? Only 2.2 months. This is shown in the Rainbow study where patients were randomized to RAM paclitaxel versus paclitaxel alone. Here's the primary endpoint, hazard ratio 0.81, favoring Ramaseraab. As you can see, the curves merge at 13 months, indicating that the benefit from Ramaseraab is transient. Now, in a subgroup analysis, there was a suggestion that Ramaseraab had a greater effect in the Western population with a hazard ratio of 0.73, whereas it was only 0.99 in the Asian population. However, interaction test was not reported, so we don't know if this is truly different. It's interesting, but exploratory. However, even if you believe that the benefit of RAM was restricted to Western patients, the benefit is still only 2.7 months of OS. So how does RAM Taxol compare with other recent positive gastric trials? There are no second-line trials for comparison because there are no large ones that showed an improvement for an intensified regimen over chemotherapy alone. So how about first-line trials? There's TOGA in the HER2 subgroup approved by the EMA, TOGA in the entire population, V325. By comparison with these studies, Ramaseraab had a less impressive hazard ratio. The RAM combination was reasonably tolerated, with the exception of grade 3 bleeding, which was uncommon, but twice that of the placebo arm. So how about RAM monotherapy? Monotherapy added 1.4 months of overall survival to best supportive care alone. Hazard ratio, again, modest at 0.78, barely statistically significant. The limited benefit is shown by the fact that for almost half the patients, they had an event at the time of first disease assessment, which is around 2 months. How does RAM monotherapy compare to chemotherapy alone? The median improvement is about the same in all the trials, about 1.5 months. But if you look at the hazard ratio, which arguably is a better indicator of overall benefit, the hazard ratios are more prominent for Chemo Alone compared to Ramaseraab. So it certainly appears that RAM has no better efficacy than Chemo Alone and maybe a little bit worse. Now we should acknowledge that RAM monotherapy seems to be very well tolerated. However, the treatment duration was only 8 weeks, which is about 4 doses, so we would not expect a great deal of toxicity to have been reported. Does Ramaseraab improve quality of life? There's no evidence that it does. For RAM monotherapy, QOL data was collected at 6 weeks, but was missing in more than half the patients of the RAM arm and about 3/4 of patients in the placebo, mostly because patients had already discontinued therapy by then. QOL was improved in 10% of the RAM arm versus 4% of chemo, but the difference wasn't statistically significant. The investigators could only conclude that RAM was no worse than placebo for quality of life. Same goes for the RAM-paclitaxel combination. End of treatment QOL scores were the same in the RAM and placebo arms for both surveys that were utilized. And the investigators concluded in the peer-reviewed paper that the addition of RAM only maintained quality of life. Now, some symptom scores were released in the abstract, but to my knowledge, which of those were statistically different has not been reported. Be interested in see if that is made available. On the other hand, symptom and QOL scores were extensively reported in a full publication for the Cougar study. The blue bars are those showing that the symptom scores favor docetaxel over best supportive care, and the red are those favoring supporting best supportive care. As you can see, docetaxel was better in most symptoms and dimensions, and statistically favorable scores for docetaxel were observed for pain, constipation, nausea, vomiting, and dysphagia. So I think anyone would agree that the outcome benefits for Ramaseraab are modest. So we'd expect a modest price. These are the drug prices in the US. Obviously, this is an enormous difference. RAM is priced very similarly to aflibercept before aflibercept's price was cut in half when Memorial publicly decided to exclude it from their formulary. This price does not include doctor's fees, supportive medications, or diagnostic tests. Now, Lilly does offer a copay program that pays for almost all the cost of Ramaseraab. But there's a catch. The program excludes government-insured patients, which are 60% of cancer patients, and that percentage is increasing. These are the very patients at highest risk for financial hardship. So many patients will have to pay a 20% copay. This means out-of-pocket costs for Ramaseraab monotherapy of $4,800 a month if you receive, $4,800 total if you receive the median duration observed in regard, and almost $11,000 out of pocket if you receive the median duration observed in Rainbow. For the elderly on fixed incomes, this can have a detrimental effect. Surveys have shown that 25% of cancer patients have used up most or all their savings paying for care. There's a 2.7 times higher rate of bankruptcy among cancer patients compared to controls, and 10% of cancer patients spend more than $18,000 out of pocket on their care. It's possible drug costs may decrease in the future, biosimilars may be developed, et cetera, but for now, in the US, for the patients that we'll be treating on Monday, Ramaseraab remains expensive. At least 2 groups have now published criteria on what they believe are minimum outcome improvements that a drug needs to demonstrate to be considered clinically meaningful. By either criteria, RAM falls into the bin of expensive FDA-approved drugs that are not worthwhile. The group led by Dr. Sobrero evaluated 43 trials of FDA-approved drugs. They believe that therapies, which are both expensive and toxic, should meet a high threshold of outcome improvement, whereas therapies that are both less expensive and non-toxic could meet a lower threshold. Ramaseraab is expensive but non-toxic, so it should meet a medium threshold of outcome improvement to be considered clinically worthwhile. So they developed threshold values across 4 parameters of overall survival: hazard ratio, change in the median, percent of patients alive at 2 years. And in addition to drug expense and toxicity, the thresholds differed based on the baseline prognosis of the tumor type. For patients in this prognostic group, less than 9 months OS, which is second-line gastric, the hazard ratio thresholds were set at 0.65, median improvement of 2.5 months, 10% absolute, and a 50% relative improvement at 2 years. I applied their criteria to Ram plus paclitaxel from Rainbow. Failed every parameter. Are the thresholds too stringent? How would TOGA do? Remember, TOGA tested the addition of trastuzumab to chemotherapy in first-line gastric, priced at $5,000, half that of RAM, also non-toxic, so it should meet a low threshold of outcome improvement. TOGA met every parameter. How about RAM monotherapy? As shown in Regard, the comparison trials would be the Korean and the Cougar trials. As you can see, none of the regimens perform very well, but the Chemo Alone trials perform a bit better. Now, ASCO's criteria for minimum outcome improvement incorporated the opinions of patients and other stakeholders. In the interest of time, I'll summarize that the ASCO thresholds were similar to that of Sobrero and colleagues, and if you extrapolate the recommendations to gastric cancer, RAM, again, does not provide clinically meaningful benefit, though chemotherapy alone at least meets 1 parameter of hazard ratio. Now, as a caveat, these thresholds, of course, have limitations. Some of them are listed here, but their development reflects a growing perspective in the oncology community that small, expensive gains from drugs like Ramaseraab in gastric cancer, second line, are not worthwhile. So in summary, RAM is not appropriate in second line, either combined with paclitaxel or monotherapy, because it lacks value. Is a 2.2-month improvement in OS from the combination worth $12,000 a month? Is an additional 6 weeks from monotherapy worth $12,000, especially when chemo alone adds similar, if not greater, efficacy? As Dr. Shilsky and others have noted, we often celebrate small incremental gains which over many years have cumulatively translated into big improvement. Look at the example of metastatic colorectal cancer. But the time has come to accept that drug cost matters, and the failure to acknowledge this is hurting our patients. Most patients wouldn't pay $12,000 for a drug that improves survival by 8 weeks. Trastuzumab's benefit in first line is closer to the mark, till something better than RAM is developed in second-line gastric, or RAM is set at a lower price. Chemotherapy alone is most appropriate. Thank you very much.